Hello, I'm Dr. Lori Morgan, President and CEO of Huntington Hospital. Welcome to our first virtual donor appreciation lunch. This is a whole new thing for us. While our gathering is virtual, our appreciation is real. In these extraordinary times, I'm extremely proud of our clinicians' dedication to serving this community, and I'm equally proud and grateful for your commitment to them. Whether you are a longtime President's Circle member or new to our donor family, thank you for answering our call and helping us in so many ways. Thanks to your generosity, our COVID-19 Response Fund has garnered over $1 million to help us offset the high costs of providing care for COVID-19 patients. You should also have seen the very long line of cars for people who were donating personal protective equipment, masks, gloves, and other things that we needed at the very start of the pandemic when we needed it the very most. With the fourth highest volume of COVID-19 patients in the state of California, Huntington Hospital has been tested. But in large part, and with your assistance and thoughtful support, we have responded with confidence and preparation. And now as we move forward to what we are calling our next normal, we are providing health care during an ongoing pandemic. We will likely have a COVID unit in our hospital for a long time to come. We will continue to suspend our volunteer program and keep our visitor policy very restricted. However, as we move forward, we have taken down our surge tents as we do feel we are prepared to care for patients within the walls of our hospital. We have returned to providing elective surgeries and intend to do this as long as the volumes of patients allow us to do so. We will do this in a safe and responsive manner. We'll be there for elective surgeries and always continue to provide the emergency care, cardiac emergencies, strokes, trauma that we have for the last 127 years. I want to, excuse me, I'm sorry. Having a little bit of problem here. I really want to assure you that we are here for you in these challenging times. And aware that the pandemic remains at the forefront of all of our lives and will for the foreseeable future, we're pleased to provide you with some up-to-date information on COVID-19 today. I am so happy to have with me today Dr. Kimberly Shriner, our infectious disease specialist, more than 6 feet away from me. She knows Pasadena well. She is one of our hometown heroes as she was raised in Pasadena. Dr. Shriner did her undergraduate degree at Occidental College and then went to medical school at Case Western Reserve. She came back home to do her internship and residency at Huntington Hospital. She then did an infectious disease fellowship at UCLA and then returned to Huntington Hospital where she's practiced for the last 30 years. She has become a very local expert, providing lots of information to the media and has been a tremendous support for us as we have forged our path in terms of the best way to care for our patients in the hospital. As we shift mics and I get more than 6 feet away, please join me in welcoming Dr. Kimberly Shriner.
Thank you, Dr. Morgan. It's truly my honor to be here and to provide a little bit of an overview of the current pandemic. But first of all, I would like to echo Dr. Morgan's statements about the support that all of you have provided for the hospital. Pasadena is a very unusual community, and we are very appreciative of all of the people that have contributed to our COVID fund, but who also support the hospital on a regular basis. I think that it's a very unusual place to work. I'm honored to be part of the Huntington family. And I would also like to commend Dr. Morgan for being an amazing CEO during a very, very difficult time. She really is a true leader, is able to make hard decisions, but is a great listener and puts up with an awful lot of questions and comments during our meetings, but we are so grateful to have her during this very, very difficult time. So what I'd like to do today is provide you with an update on the pandemic, and as you probably all know, a lot of the statistics are old already because things are rapidly changing. This is a very unusual event that's happened to all of us, and it is a very challenging one as a clinician and an infectious disease specialist. So I'd like to sort of review the aspects of the pandemic and some of the aspects of the virus, and hopefully give you a better understanding and perhaps give you some sense of calmness about how we're going to deal with this, because I do believe that information and fact-based data is the most important and most powerful tool that we have to deal with a very, very difficult disease. The global situation right now, of course, these numbers are old already. This was from last week, but we're approaching 9 million people throughout the world that are infected with coronavirus. Of those, we are also fast approaching 500,000 individuals who have died from this disease. In the United States, we have over almost 23 million cases now confirmed, and sadly, we have surpassed the 100,000 mark for a number of deaths with coronavirus, a very, very disturbing statistic. 600 people a day in the United States are becoming infected with coronavirus, and so this is a very potent and infectious pandemic that is taking a lot of, creating a great deal of deaths and disease throughout our country and really throughout the world. LA County is one of the highest affected counties in California. Of course, it's one of the most populous counties, but right now we're about almost at 84,000 confirmed cases in Los Angeles County with about 3,200 deaths. So these statistics change every day, and I'm sorry to say that they are not getting better at the moment. Plagues and pestilences have been part of humanity since we stood up and walked and ran away from the first lion. There's very good documentation of prehistoric plagues that have been found in China very, very early on that apparently wiped out some civilizations there in 5,000 or 6,000 years ago. Some of the first documented plagues occurred during the time of the Greeks. In 430 BC, there was what appeared to be a typhoid fever or diphtheria outbreak in Athens that took out a large portion of the population. Famous plague in Rome was the plague of Galen, or the plague of Rome, that occurred in 165 AD. That was likely smallpox. And then, of course, perhaps one of the most famous pandemics was the Black Death that occurred in the Middle Ages in Europe. Took out about 25% of the entire population of Europe. And so, of course, was bubonic plague at the time, a disease transmitted by the fleas that lived on rats. The United States and all the Americas have had many plagues. Smallpox, of course, was brought by the Europeans and wiped out large populations of indigenous peoples, as did measles and various hemorrhagic fevers. So this is not something that is new to our species. We even have, of course, more recent pandemics that some of us perhaps can even certainly remember. Perhaps not the 1918-1919 H1N1 Spanish flu epidemic. That took about a third of the population of the world became infected, and over 50 million people died from the disease. We've had two significant, recurrent significant influenza pandemics, one in 1957, one in 1968, and of course one in 2009, the H1N1 influenza virus pandemic. Of course, the second most important pandemic probably in this century, maybe the first one in terms of the number of people infected and ongoing infections, was the HIV pandemic in 1981. And there are very many parallels between that pandemic, though it was is a different pathogen and transmitted in a different fashion. There are certainly parallels between the HIV pandemic and the current coronavirus. I started my career in infectious disease with the HIV pandemic when it was raging in the 1980s. And of course, it's been an enormous challenge to deal with that disease. Over 30 million people have died from HIV during the 35 years of the pandemic. But we now have highly effective therapy that really has made an enormous difference in mortality. However, a good lesson to be learned is that there does not appear to be a vaccine easily available for HIV itself, something that we hope will not be the case for coronavirus. There have been some smaller outbreaks, the Muerto Canyon hantavirus outbreak that occurred in the Four Corners area. And then, of course, the first SARS epidemic that happened in 2002-2003. Similar to this one, also a coronavirus, but not as global as this disease has been. In 2014, of course, the Ebola outbreak that was largely confined to West Africa was very scary. We did have a couple of cases in the United States, but not on the level that we're dealing with right now. So what is SARS-CoV-2? This is the virus that causes the coronavirus, or COVID-19, which is the actual name of the disease. This is an RNA virus, a common genetic modality for many viruses. It has the largest genome of any RNA virus. It's a very common virus. It is, of course, the common cause of upper respiratory infections, colds, and can also cause lower respiratory infections, bronchitis, and ARDS in the alpha coronavirus family that largely affects humans. The beta coronaviruses tend to affect birds and mammals as well, and that's what this virus is. This is a beta coronavirus, not an alpha coronavirus, which is largely an animal-based virus. It is very clearly derived from bats. The Chinese horseshoe bat was probably the vector, and it developed a mutation that allowed this virus to attach to the respiratory tissue of the lungs, and that's why it's such an infectious and challenging pathogen. But perhaps most of all is that none of us on this planet have any immunity to this virus. It's an entirely new virus for our species, and that's why this is such a very, very difficult situation to try to address. So where did the SARS-CoV-2 virus come from? Well, this is a very classic zoonotic infection. It came from, as mentioned, the Chinese horseshoe bat. There may have been an intermediary host, which is thought to be the pangolin, which is an armadillo-like creature that's a valued meat and skin animal in some of the exotic animal markets of Asia. It is pretty clear that the bats themselves can also infect humans directly, but this virus probably jumped species very quickly. We think that the virus emerged in the November 2019 period in a wet market in Wuhan. Again, this is a place where exotic meats and animals are provided for food and also for other medicinal purposes. This virus jumped species probably in that wet market. There's some very early molecular data that shows the very first humans that were infected with it were probably in December of 2019. But what happened is that because of global travel, the virus was able to spread extremely quickly, in addition to the fact that the virus is highly contagious. So with the number of flights that go back and forth from Asia and all over the world, and of course the famous cruise ships, all of those venues have been perfect vector modalities for transmission of the virus. And so in a very short period of time, when you think about it, basically from Christmas until now, we now have an enormous pandemic that's infecting every single country on the planet except Antarctica and causing massive amounts of disease and death. And it really is a scary situation. Most of us in infectious disease had predicted a pandemic. I think we all thought it was probably going to be another variety of influenza. But it's very clear that these type of infections are going to be something that we have to pay attention to. And this one, the rapidity with which it is spread, has been really challenging. One of the questions that we have now that we're into this current pandemic is, will there be another surge? And the behavior of the pandemic is important in terms of our ability to deal with it. And I'll talk a little bit about some of the mitigation techniques that we've been using that we've had some success with. It is very common for viruses to have a seasonality. That is not something unusual. Influenza certainly does it. And coronaviruses, the alpha coronaviruses that cause the human cold, also can do that. We don't know the behavior of this particular virus and whether it's going to be episodic, but it does appear to be, although I will remind everybody that we are not in the second wave of this pandemic. We are still in the first wave. There's an enormous amount of virus that's circulating throughout the world, and especially in the United States right now. And so we never really have gotten over the first wave. It's just a very prolonged episode of infection and transmission. We know that during the 1918 and 1919 pandemic, there was seasonality to it. The first episodes occurred in the summer of 1918, and then there was a massive surge that happened in the fall and winter of 1919. That's a scary prospect for this disease because we already are seeing a very high burden of infection. If we have a bigger surge in the fall or it mixes with influenza, it could be an overwhelming prospect for hospitals and healthcare workers to deal with. And that really is the rate limiting factor for keeping this catastrophe from getting out of control. I think we all have pretty good memories of the not so distant past of New York and Italy and certainly China, where the virus was out of control and it just overwhelmed the healthcare systems. We know with SARS-CoV, with the first SARS virus in 2003, there also was some seasonality, although it was rather erratic. And in fact, that seemed to sort of burn out and disappear. And I think that was largely a function perhaps of the infectivity of that virus, but also the fact that the world was not quite as accessible as it is now with the number of travels and so forth, and the fact that SARS-CoV-2 has established itself very quickly around the world. So let's talk a little bit about COVID-19 in California right now. We know, again, that we are still in the very beginning. We're not even at the end of the beginning of this particular pandemic in the United States. We are seeing some curves in Europe that have come up and then gone back down again, which is encouraging. But unfortunately, what's happened in the United States and in California, and frankly even in Pasadena, is that we've had a curve up. We had a slight decrease due to social distancing, and then we've been sort of staying on this plateau. And the plateau still has a high number of disease. We are beginning to see another uptick in infections and spread of the disease, and that probably has a lot to do with the lessening of social distancing and trying to open up society a little bit in addition to some other factors. This is a scary curve that came out last week that looks at the daily number of confirmed new cases in California. This is not a function of increased testing. Yes, when you test more people, you find them, which is a very, very important thing to do. But what we're seeing is the percent of tests and the percent of positive tests and the number of people who are being tested is increasing. And that tells us that there's more disease, it's continuing to spread in the community, and continuing to be a problem. If you look at it in terms of LA County, again, you can see the number of cumulative cases have been increasing, as have the cumulative deaths. And you can also see that the number of hospitalizations is increasing. And that really is a factor of disease, of circulating disease. That's a very good indicator that you don't have the pandemic under control when the hospital numbers continue to increase. So I wanted to talk a little bit about Huntington Hospital's own experience. We, as Dr. Morgan said, we have had the 4th largest amount of COVID in the entire state. And that is a function in large part of the amount of disease that we have experienced in our local nursing homes. We know this disease is very problematic in vulnerable populations, elderly people, people with comorbidities. And so Pasadena has a lot of skilled nursing facilities and assisted care facilities. And for that reason, we've had a very large number of cases. We also, however, have a well-established amount of disease in the regular population that continues to circulate, and that's what we're beginning to see right now. This is a dashboard from this morning at Huntington. This gives us an idea of where the virus is moving and how it's behaving. And you can see the top curve, the blue curve, is going up. And that's not the direction that we want at all. And I think that many states are experiencing this. Arizona is almost overwhelmed. My understanding is they're very shortly going to start experiencing a shortage of ventilators. We know that Texas and Florida are becoming new epicenters. And the disease is spreading really throughout the country in areas that it previously hadn't been. So this is a very, very disturbing trend that we're seeing. And some of it is a function of opening up society. Some of it is a function of people getting tired of wearing masks and practicing social distancing. And the virus doesn't care whether it's the summertime and you've had enough of your relatives. It wants to spread to a non-immune host. And that's what it's going to do because none of us have immunity to this pathogen. The one positive thing that's happened over the last 3 to 4 months is that every day that goes by, we learn more about this virus. And it helps us in terms of how do we prevent people from becoming infected, how do we treat them if they do become infected, and what are the best ways of dealing with this in a healthcare facility. So we certainly know that this virus is very, very contagious. and that it's transmitted largely by droplets. And by droplets, we mean the small, sometimes very tiny little pieces of mucus that are expelled when you speak, or when you cough, or when you sing, or when you sneeze. And we know that those droplets are highly infectious, and that is the most common way that people acquire coronavirus. Yes, it can occur on contaminated surfaces, and yes, you can isolate virus from contaminated surfaces hours and occasionally even days after it's been put on that surface. There have been some good studies that have shown that, and I'll show those to you in a minute. But that is not the most common way for transmission. We know that this virus is most likely to be transmitted by infected droplets, and that's the way that we can help prevent infection, by masking people and having them keep at least 6 feet distance from one another. It is a sensitive virus. It's an envelope virus. They're very delicate. They don't last very long floating around in the air. There are certain situations, especially when we're treating patients in the hospital, where it actually becomes more like an aerosolized virus, much more like measles or tuberculosis. And so that is something we worry about in the hospital setting, but not so much in the general public. So that one of the best ways, of course, to reduce transmission, and this has been shown over and over again now, is to mask people. And this is just a nice little diagram that shows what a mask does. And one of the reasons that we ask everybody to wear a mask is because it prevents your mucus from contaminating somebody else. It really is much more to keep your mucus droplets away from other people than to protect you from them, although it does still provide protection to you from people who are around you. And masking is very, very efficient. Even just a simple cloth mask, even a bandana, probably provides some protection. They may not be as good as the masks that we use in the hospital. We certainly like to use very high-performance masks in situations where there's a great deal of virus. But masking the public is a very, very effective way in preventing transmission. And so there's a lot of controversy. For some reason, this has become sort of a political issue. It's really an infectious issue, and there's all kinds of styles of masks now. You can make statements, you can make political statements with your mask, you can say a little something about yourself, but we really need people to remain masked when they're outside, unless they're far enough away from other individuals that they won't transmit the virus. This was a study that was done in the Netherlands that looked at particle transmission in people who were exercising. And they do have sort of a little jet stream of particles behind them. Whether they're infectious or not is not really clear, but you can see that from these highly heat-sensitive microdroplet studies that there is some risk if you're walking behind somebody very closely who's not masked, who might be running. And so if you see a runner coming down the street and they're not wearing a mask and they're not going to move out of the way, you should probably move out of the way. But the likelihood of transmission from someone farther away than 6 feet is very, very small. And again, the likelihood of transmission outside is also diminished. It's not unheard of, it certainly can happen, but closed spaces are much more likely to transmit these infectious particles as opposed to the outdoors. This was a study that was done in the New England Journal that, excuse me, that looked at contact surfaces and the persistence of particles on contact surfaces. And it did show, again, that the virus can live on these surfaces or exist on these surfaces for two hours to a couple of days. But whether they're infectious or not is still really not very clear. Obviously, a telephone that you pick up that somebody with COVID just spoke on or and left some of their droplets, that device might in fact be a very highly infectious one. A package from Amazon, I'm not so sure. We are, encouraging people to be careful when you handle packages that are just delivered. It is sort of difficult to wipe everything down and to sort of treat everything like it's a toxic substance, but it's probably prudent to do that, although we really have no documented evidence that transmission has occurred on packages, especially packages that are left at the doorstep for hours and hours on the outside. What I do is I put on a couple of garden gloves and I bring the package in and I open it up and I take out the contents, and sometimes I wipe it down if I remember, but often I forget, and I think you just have to be careful. The other important thing, however, is to wash your hands after you handle a package, even if you're not wearing gloves. If you wash your hands, you're really going to prevent transmission. One of the things we're learning about this virus is that it's highly infectious, and this is dependent on several factors. The first is what we call the viral load, which is the amount of virus that a person may be shedding at any one time. And we know that people are most infectious about 2 to 3 days before they actually start becoming symptomatic. You hear this expression of asymptomatic carriers, and that isn't like some sort of a typhoid Mary who's going around who doesn't have any symptoms and is spreading the disease far and wide for long periods of time. Asymptomatic carriers are probably people who have very minimal amounts of symptoms, and they continue to shed virus for probably a fairly short period of time. We don't know whether that's always true with every single patient. There is some evidence that people continue to shed virus for several weeks, even after they've recovered from their symptoms. But the vast majority of people and the vast majority of infections occur from someone who's either early in the symptomatology of the disease or not symptomatic yet and is shedding a great deal of virus, and they're the most infectious. The other really important factor in acquiring coronavirus infection is the length of time of exposure. The longer you're around somebody who's shedding virus, or the longer that you're in a room where there's virus circulating, the more likely it is that you can become infected. And that's why you may see that we want to keep exposures to patients when we're dealing with them limited, trying to limit the amount of time that healthcare workers spend with the patients, which is unfortunate for the patients in terms of support and so forth, but really trying to keep that exposure time down because that increases the risk of transmission, even in the presence of very good personal protective equipment. And then finally, this virus is a very, very contagious pathogen. It has developed mutations that allow it to attach very effectively to human nasal mucosa and human lung tissue. And that's a receptor site called the ACE2 receptor site, and it's unique to this particular species of virus that it's allowed it to attach very avidly to that kind of tissue. And once it gets a foothold, it takes off and causes obviously very severe disease. We measure infectivity with the value called the R0 value, and basically what this represents is what's the likelihood that a person with COVID is going to transmit it to another person, and how many other people could it transmit the virus to. So when we have a very high level, a high R0 value of 2.5 or 3, excuse me, that means that that one person with an infection is likely to infect 2 or 3 people. Highly infectious aerosolized pathogens like measles, their R0 value, the R0 value there is anywhere between 5 and 200. And so a person with measles could walk into a large room like I'm in right now, filled with people, and infect 25 or 30 people, even people across the room, because that's an aerosolized particle. This virus is not an aerosolized particle most of the time, and so, but it is highly infectious. And so a person with COVID can walk into a room with 100 people, and 2 or 3 people that are close to that person may become infected just from the virus being around in that environment. You can make the R0 value go down by social distancing, by having people wear masks, and by decreasing the amount of virus that's circulating in your community. Taking individuals who are infected, having them isolate at home, trace down all of their contacts, have them isolate at home. That's how you deal with this virus, and it's a very, very effective modality. You see the results of that in countries like New Zealand, which has not had any cases in the last week, I believe, and South Korea, which has handled, they've only had 800 deaths, and much, much different scenario in these countries because of very good contact tracing, isolation, and decreasing that R0 value down to less than 1. So we talked about the infectivity of SARS-CoV-2 and the importance of social distancing. When you loosen social distancing, which you have to do to get your economy going again, you are going to see that R0 value go up, and you are going to see more cases. What's happening right now, however, is we're seeing more cases than we would expect to see just by opening up society, and that tells us that people are not paying attention to social distancing, are not wearing masks, and also we have activities that are happening, whether people are going to the beach and there's lots of people there and they're transmitting the virus in that fashion, they're going to social events, birthday parties, etc., or they're on a march protesting injustices of society. All of those activities where you have large groups of people together, even if they're masked, increases the opportunity for the virus to spread. For this particular pathogen, then, the risk factors that we are worried about in terms of a lot of disease are age. We know that this virus is much more aggressive and much more deadly in individuals who are older. Although I will remind everybody that this also can be very significant in young people. I have a 39-year-old patient right now. We've had many patients under 40 some of whom have not survived. So this is not, it's a pathogen that doesn't really care that much about your age, although older people are more likely to have more difficult times with this disease and perhaps a poorer outcome. Probably the most important factor with coronavirus is the presence of congregate living situations. And I think what the catastrophe that's happened in skilled nursing facilities all over the world, not just in Pasadena, speaks to that problem. The infectivity of this virus, the fact that it spreads quickly from one person to another, and none of us have immunity, makes the congregate living situation, whether it's a skilled nursing facility, a dormitory at a college, many people living in a small house, a fire department, a living situation, anywhere you have large numbers of people living together and not in socially distant fashion, you can have spread of the disease. And so that is a very, very important risk factor in populations, in emerging populations, and that's what's happened largely in the skilled nursing facilities around the country. Your occupation obviously puts you at higher risk. Again, that has to do with chronic exposure to the virus and duration of exposure. So for example, if you're going to the grocery store to buy your groceries, and you're wearing a mask and you're wearing gloves, you're very likely not to become infected because you're taking appropriate measures, you're in and out of the store quickly. Hopefully, like Trader Joe's, they have a lineup where people are spaced apart and they limit the number of people into the store, and your exposure time in there is relatively short. It's different for the individuals who work in those stores because they're there for 8 hours or 12 hours. So even though the public is wearing masks and even though they're wearing masks, they're in that environment where they're likely to be exposed to the virus for long periods of time. That's true of many of our first-line individuals like bus drivers, and of course certainly healthcare workers, and the first responders, the EMTs, the police department, school teachers. The longer you're exposed to the virus in a congregate collection of people, the more likely it is that you can acquire the viral infection. So occupation is very important. And it really speaks to who has become infected with this virus when you look at all of the other factors. There is a gender predilection with this particular virus. It does seem to be more aggressive and often with a poor outcome in men. And we don't quite know what that reason is. It probably doesn't have to do with estrogen, because we know that postmenopausal women still have an advantage over men. So it probably isn't the presence of estrogen. There was some thought about using estrogen as a therapy. That has sort of fallen by the wayside. It probably has more to do with either the expression of ACE2 receptors, which is more common in men, in large part because men tend to have traditionally been more likely to be smokers and have occupational pulmonary disease. But there may be something about testosterone that increases the expression of these receptors, and interestingly enough, the ACE2 receptors are found in abundance in the testes. So that may be an area where the virus can hide and then continue to provide viral shedding. So that may account for some of the gender discrepancies we see with this disease. That's still being studied very carefully. This definitely has socioeconomic impact on society, but more importantly, it has disproportionately affected people in lower socioeconomic levels. And that is a very, very serious social problem that we're going to have to deal with. Poor individuals often live in congregate living situations. They can't afford the terrible rents that we have around LA County, and so they have multiple people living with them. They may have multiple jobs to try to make a living. So this has really been a very, very big factor in the disproportionate burden that lower socioeconomic individuals have had to bear with this disease. And it's certainly something that we need to address as a society and also in terms of how we provide health care. We talked about the duration of virus exposure, and then finally, often one of the most important things are what we call comorbidities. So the presence of other diseases, particularly diseases like diabetes, hypertension, cardiopulmonary disease, obesity. These are very common diseases in our society, and they put individuals at higher risk for a bad outcome if they develop coronavirus. So let's just talk briefly about the pathogen, the virus itself. Of course, it's called coronavirus because it has these little spikes that surround this little sphere, and those spikes make this kind of corona crown-looking appearance to the virus. These are some very interesting 3D images that were produced a few months ago. Excuse me. The spike protein is not only unique to the coronavirus, but it also is of high importance to the coronavirus because it is the attachment site of the virus to human epithelium, and it attaches very avidly. Once it finds a human receptor site. It attaches very, very strongly to the epithelial cell, and then takes the cell hostage and makes the cell into another virus factory, kills the cell in the process, and then creates more virus. So the spike protein on the coronavirus is very, very important. There are three other important proteins with this virus. They may be of significance as we begin to develop antivirals, because all of those proteins are involved in viral replication. But right now, much of the focus, both from vaccine development and also in therapy, is on the spike protein, because that's the first encounter that the virus has with the host. That's how it attaches to the host, and that's the most important part, and probably one of the more unique parts of this particular virus. As I mentioned, the S protein, or the spike protein, mediates attachment to the cell, and it also allows the virus to bring in other cells around the area of attachment. And so it kills those cells. So you have these large multinucleated cells, or syncytia, which are like rafts of dead cells in an area where the virus is infecting. And you can see that in our patients. They start out with a very small little bit of pneumonia, and then they begin to develop more and more areas of pneumonia, and that's really what's happening on a microscopic level. One of the other unique features of this virus is the inflammatory response that it elicits from our own immune system. It makes the immune system basically become totally unhinged and have a profound and dysregulated reaction. In other words, when you encounter a virus, your immune system gives you a fever, it may give you achy bones, you may develop mucus. Those are all your white cells trying to fight off the infection, and that's a normal response that lasts for a couple of days. You get over it and you move on. What this disease does is it takes the immune system hostage, and it allows the immune system to basically go haywire, so that it has a very inappropriate, over-exuberant response to the virus, produces very high fevers, produces low blood pressure, and certainly affects the lung, producing very severe pneumonia that progresses very rapidly, and you can't oxygenate these patients very well. And it's that immune inflammatory response that causes the disease itself, which is something very important, because we are beginning to learn how to use anti-inflammatory medications to help tamp down that response a little bit from the virus. But there's clearly a relationship between the immune response and some of these other comorbidities like diabetes and immune suppression, patients with cancer, patients that have other kinds of underlying immune disorders. That certainly increases their risk for this disease, and it's largely in part due to the actual disruption of a normal immune response. Finally, one of the more important things that happens with this disease is the development of little tiny clots, microemboli, and they can go to the brain, they go to the lung, they can go to the heart, and that produces tissue damage locally there, and so it accentuates all the damage that's happening with the virus. This is a CAT scan of one of our patients. You can see the shadows on the periphery of the lungs are the dark tissue, and all the shadows on the periphery of the lungs reflect disease that's happening in the lungs. It's that inflammatory response, cell death, forming these big rafts of dead cells, and that plugs up the lungs so that you can't oxygenate. So these patients become more and more short of breath and eventually have to be put on a ventilator. Although the lungs are probably the first and most important organ system that's infected and affected by this disease, it certainly can affect other organ systems. We know that there are inflammation of the heart situations. We know that it can affect the kidneys and cause kidney failure. There's encephalopathy when you have infection in the brain. We know it dysregulates the immune system. We know it dysregulates our ability to clot. It makes us hypercoagulable. And it may even have some reproductive aspects of the disease. We know that the testes can be a sanctuary for the virus. Some of you have probably heard about the pediatric hyperinflammatory immune syndrome, and this has been recognized in the last few weeks, really. An unusual and thankfully relatively rare phenomenon that occurs after a child has had coronavirus infection, and they develop this kind of inappropriate, again, immune reaction where they develop low blood pressure and funny rashes and very, very high fevers, and it has a very high mortality, unfortunately. We do have children that survive this, but it is similar to some other diseases we've seen with other viruses. It tends to occur after they've recovered from the initial infection with coronavirus. The Chinese were very quick to identify that this disease did not occur very commonly in young children. And that may be a function of the fact that they don't have a lot of ACE2 receptors. They're beginning to develop their immune system. Their immune system is very immature, and so it may protect them a little bit from all the really draconian effects of this virus. That said, we are now recognizing once again that coronavirus can infect children, can affect children, and also children throughout all ages. And certainly they can serve as a virus factory and be a source of infection to people around them. So the sort of adage that if you're younger you're going to do better isn't always true for this particular disease. This was a publication in the journal Cell that talked about the targets of neutralizing T-cell responses in coronavirus. And again, our understanding of how the immune system responds to this disease is going to be important in how we develop a vaccine for this disease. So again, what happens is the immune system becomes dysregulated and it creates this storm of inflammation. And that leads to all of the symptoms that we see with coronavirus and often to death. And that's what makes it such a very, very severe disease. This disease has a much higher mortality than influenza. In certain populations, it has a very high mortality. If you have a lot of the comorbidities, then the likelihood of having a very bad outcome if you get severe coronavirus infection is fairly high. And so that's why it's such a very, very big challenge to deal with this. So how do we make the diagnosis of this disease? Well, we certainly want to take a history. Certainly if people have had exposures to someone with a documented disease or they have an atypical pneumonia, that is worrisome. Right now, we really want to look at every patient who comes in who's short of breath with a fever. And of course, sometimes that isn't coronavirus. Sometimes it can be influenza. We had 62,000 deaths due to influenza last year. We're very worried about this virus and how it's going to behave with the upcoming influenza season in the fall. But it's a constellation of symptoms, fever, of course, being one of them. Not everybody has a fever with this disease. A dry, non-productive cough usually, sometimes headache, often very achy bones, myalgias, occasionally some gastrointestinal symptoms, diarrhea, nausea, and this peculiar symptom that many patients report, even if they don't have a lot of the other symptoms, of a loss of sense of taste and smell. And what happens is the virus attaches to the nasal epithelial cilia in the back part of your nose. That's where you sense taste and smell. And the virus attaches there very quickly and damages those nasal cilia very quickly, sometimes irreparably. And that's why people seem to have that peculiar symptom. Many of them regain it later. And often those people don't have a lot of other symptoms afterwards, but that's a very classic, very early sign of coronavirus infection. Of course, we talked about contact risk factors if you've been exposed to someone who has the disease. And then finally, the SARS-CoV-2 PCR, which is the molecular test you hear about, that we can very effectively test for the presence of the disease. This is a graph that just sort of shows where in the course of time things become apparent. Let's say you get exposed at time 0. There's an asymptomatic period of about 4 days usually in most people, 4 to 7 days where they won't have any symptoms, but usually most people develop symptoms if they're going to become symptomatic within 4 to 5 days. And some of those symptoms may be very mild, they may be very short-lived. Depends a little bit on the virus that you're exposed to, how much and for how long. Some of them, of course, begin to have more symptomatic through the week. The second week is the time we worry the most about people with this disease. That's often when the symptoms really take off if they're going to have a severe problem. And that would include more shortness of breath, more cough, more chest pain, more malaise, and so forth. But usually after about day 14, day 21, they will recover. And remember that 80 to 85% of people who get this disease do recover. They may have a very bad influenza-like illness, but they do recover. But that means that 20 to 25% are going to have a rougher course. They may require hospitalization. And then of those, 5 to 10% of those people may actually die from this disease. You generally develop antibodies, which are the immune system's response to the virus, within about 14 to 21 days. What's peculiar to this virus, and I've seen it in a couple of my own patients, is that some people continue to shed virus even after they've recovered and even after they've developed antibodies. So the presence of antibodies doesn't mean that you're no longer infectious. And we can actually detect virus in people even if their antibody levels are quite high. And so that is of concern because they may continue to be a source of ongoing infection. The presence of antibodies is a good sign, we think, and it's what we're hoping for a vaccine, but we don't know how long those antibodies are protective. Is it 3 months? Is it 6 months? Is it 2 years? It's probably not lifelong. Coronaviruses tend not to be lifelong protection for lifelong infection. But we hope that it's more than 6 months, because that will be absolutely necessary for vaccine development. One of the biggest catastrophes in the United States was our lack of testing. And I think that it really speaks to the importance of having a robust CDC, a robust response on the federal level to maintain the health of the country. We had very poor testing at the very beginning. We went about 7 weeks without adequate testing. And I can remember many conversations on our SARS-CoV-2 meetings with Dr. Morgan when we were struggling with trying to get people tested. Many patients came in with symptoms into our emergency room. We suspected they had coronavirus. We couldn't test them, and so we had to send them home and just tell them to self-isolate just because they were likely to have it, but we couldn't prove it. Fortunately, as time went on, we were beginning to develop better testing and access to more testing. We had a couple of other hiccups when we didn't have enough supplies for testing. The best test for coronavirus is what's called a PCR, polymerase chain reaction test. It requires a very long swab called a nasopharyngeal swab that goes down and tests and samples the deeper areas of the nasopharyngeal area. And you have to have somebody who knows how to do it very well, and it requires a very special kind of swab. So all of those pieces had to be in place before we could have widely available testing. We were very proactive in trying to get more testing available in Pasadena. And some of you might remember that we had a testing site down at the Rose Bowl that was run by LA County, but it was staffed by the true heroes of this infection, were the nurses of Huntington Hospital. They were down there testing every day. I think they ended up testing about 4,000 patients, I believe. It was a very easy drive-in test, and there's still places around the county that are doing that. So it's a very, very important thing in terms of continuing to monitor this process. The other tests that we have available are antibody testing. Now, the antibody testing, I think everybody was hoping that, oh, I had a really bad cold back in March. I hope I had coronavirus and I got over it and I have antibodies. Unfortunately, most of the widespread antibody testing assays that we've done have not shown very high prevalence of antibodies in the population. There have been a couple of large studies that have been done in LA County. There's one that was done up in Santa Clara County, and all of those studies come up with a number of about 2% right now. We did a study looking at all the first responders, the police department and the fire department in Pasadena. We tested about 222 individuals. Only 6 of them had antibodies, and all 6 of those individuals knew that they had coronavirus. So it isn't very common, and that tells us that the herd is not immune. And that means all of us are still very susceptible to this particular pathogen. So the presence of antibodies, although it is an important assay to monitor the population, it doesn't really have much help in terms of determining how the pandemic is traveling through the population. I mentioned the fact that we also don't really know what the presence of antibodies means in the way of immunity. Does it mean that you're not going to get it again? Does it mean that you could get it again and have a worse outcome? We don't know. We do know, however, that in monkey studies that antibodies appear to be protective, and also that individuals who receive convalescent plasma from people who've recovered from COVID do better. So probably the antibodies do indeed provide protection. Whether they provide true immunity or not is still not clear, and most of those studies are still ongoing. These are the 2 studies I mentioned about epidemiologic testing. I won't spend too much time on that. Again, what we're looking for to develop a vaccine or people who have had the disease is the presence of neutralizing antibodies. These are these big, large molecules that are an important part of your immune system that respond to infection. And we want to see those antibodies go up after infection with coronavirus. There have been quite a few good studies done in rhesus macaque monkeys that have shown that you infect a monkey with SARS-CoV-2, they become symptomatic, they recover, and then you re-challenge them about a month or 2 later and they don't get the disease. Now, whether if you re-challenge them 6 months later, we don't know yet, but that's going to be very important information to obtain with regard to the development of neutralizing antibodies. So in the interim, what can we do? Well, the first thing we have to do is personal protection. And this is all about social distancing and masks and having appropriate PPE and good hygiene. Washing your hands is still one of the single most important things to prevent any type of infectious disease, but in particular this infectious disease. Traditionally, hospitals have always had poor hand washing among, I'm sorry to say, the most likely culprits are the doctors. And I think the best we could do often was 25 to 30%. We now have 100% hand washing in our hospital because people have really stepped up and recognized the importance of this. Social distancing, we've talked about. Again, it's very important to try to maintain distance, especially if you're unmasked. I'm unmasked right now, and I'm very far away from everybody in the room, and they are all wearing masks. Gloves are helpful. The problem with gloves, it sort of gives you a false sense of security because you still may touch your face, and if you touch a contaminated surface, that is a problem. So gloves are not necessarily that helpful. Washing your hands is probably maybe more helpful. Wearing gowns, we certainly do that in the hospital, and of course then more sophisticated equipment that we do for our physicians that are physicians and nurses who are taking care of these patients. The different types of masking we've spoken about before. The droplet protection is wearing a surgical mask. Really any mask can help you. I will make one comment about there's some N95s that are used in the industrial sector that have a vent on the front of them, and you'll see that people wearing those. It's nice because it decreases the humidity around the mask and your glasses don't fog up. I'm in a perpetual state of fog most of the time. But these masks are not effective in preventing your droplets from being spread because just like you can vent the hot air that's in the mask, you're also venting droplets. And so those are not a good mask to wear, especially if you're going to be around lots of other people because it doesn't protect them from you. The N95 masks or N99 masks, which I know a lot of industries like the film industry use, are the most protective in terms of droplets. They are also one that have been a scarce resource. There were a couple scary times when we were talking about our supplies that we got down to about 2 days worth of N95s. And so, again, maintaining high levels of PPE is so very important for hospitals and the federal government to have a big backup of PPE. And then finally, our healthcare workers can use PAPRs, which are more sophisticated, complex systems that have an air device that pumps in, and these are highly protective. They're very cumbersome. It takes a while to put them on. It certainly takes a great deal of care to take them off because you can contaminate yourself if the surface on the PAPR is contaminated. So doffing is a very, very scary thing with those particular types of protective devices. I want to talk briefly about therapies because we don't really have very many. We hope that as we move forward through this pandemic that this becomes an area of great interest in the pharmaceutical industry and that they will begin to produce therapies that are more effective than the ones we have. Although I think all of us are looking to a vaccine for getting us out of this hole, I kind of believe that therapies may actually be the way to do it. And a very good example of that is HIV. HIV, of course, we don't have a vaccine. The vaccines for HIV have been really miserable failures. And some of that is the nature of the virus. I hope that doesn't happen with this coronavirus. I do think a vaccine is possible. But what we've done in the world of HIV is develop very, very effective therapy. We can treat people who have the disease. We can give these medications to people who don't have the disease, who are at high risk of acquiring the disease. And we can give medications to people who don't have HIV but were exposed to HIV. Those are called therapy, pre-exposure therapy, and post-exposure prophylactic therapy. And they are all highly effective. And that might be a very effective way of controlling this pandemic. There is a great deal of interest in this. There are companies such as Gilead Health Sciences who are very facile at developing viral platforms. They provide many of the HIV medications. And they are also the ones that have produced Remdesivir, which you've heard about, which is the only antiviral that we have right now. But it is certainly not a game changer. It has it helps patients, but it doesn't cure patients. And so I think there is a real need to develop potential therapies. And there are many targets for the therapies. We could certainly target the proteins that the virus has, especially the spike protein, to prevent attachment at the very beginning. We could target the proteins that cause viral replication. That's what HIV medications do. We could interfere with the inflammatory response, and we do have medications readily available that we can use to do that. So I think that therapies are going to be a very important part of trying to get this pandemic under control. I mentioned Remdesivir. It's an intravenous medication made by Gilead Health Sciences Pharmaceuticals. It does interfere with viral replication. It has broad spectrum activity against many RNA viruses, including SARS-CoV-2. Unfortunately, it's an intravenous medication. It was recently fast-tracked and approved by the FDA, but that has also led to the possibility that we may run out of this medication in the next month or two. We've used it extensively at Huntington Hospital with quite good results. This was some data that one of our infectious disease pharmacists put together. This was a few weeks ago. We had enrolled at that time about 26 patients, 17 of which completed a 10-day course. 9 of those individuals were discharged. Only 3 expired. It certainly does seem to lessen the symptomatology and increase the likelihood of survival. But again, it's not a game changer. It's a very hard drug to give, and we're very worried that the supply for remdesivir is going to become more scarce in the ensuing months because it now has been approved and can be used for many patients. This is a medication called EIDD-2108. It's interesting. It still is in its development, but it's interesting because it's a novel antiviral that causes a terminal mutation in the SARS-CoV-2 replication process. It's an oral medication, and it could be used both as therapy and prophylaxis, whether it's pre-exposure prophylaxis, perhaps give it to healthcare workers who are taking care of patients with COVID, or post-exposure prophylaxis, perhaps a family member who was exposed to someone who had coronavirus, and certainly for therapy. And the fact that it's oral is a very important advantage. It's very early in development. It's only been looked at in mice, but they are moving on to primates. I'm briefly going to mention hydroxychloroquine. This drug never was an effective therapy for this disease, and in fact, through numerous studies, some of those studies have been criticized because of some of the collection techniques, but they're still good studies. It's very clear that hydroxychloroquine does not treat this disease, and it actually can cause deleterious effects, and so it really should be taken off any kind of protocols for treatment. I mentioned convalescent plasma. This is plasma that's harvested from people who've recovered from coronavirus, and it also seems to have some help in people, especially individuals who are very sick. So we are asking people who have recovered from coronavirus if they're interested in donating their plasma, they can contact the American Red Cross. We've been very lucky at Huntington to have access to this, and we use it with great regularity, especially in our older patients where it's a very well-tolerated therapy. You just give it once, and it does seem to help. Again, it's not a game changer. People can still die when they receive convalescent plasma, but it certainly does help. So vaccines are going to be a very big lift for this disease. Again, we don't know how long immunity lasts. We think that it may be several months. The ability to do a successful vaccine normally takes 5 to 6 years between identification and development. There are about 5 companies that are right now accelerating. There are about 80 companies making vaccines. There's about 5 companies that are fairly far along in development. Again, rhesus macaque studies do show that if you vaccinate these animals with a DNA vaccine, and it's a partial killed virus vaccine from SARS-CoV-2, that they are protected. So there's some animal data to support the use of vaccines and the efficacy. You probably have heard about Moderna Pharmaceuticals. They have what's called an mRNA vaccine, and they released some very promising data on only 8 patients, however. They are currently entering phase 2 trials. They're opening up a larger number of people that will be vaccinated and then follow their antibody response to the vaccine. No previous mRNA vaccines have been approved yet. This is a newer modality for making vaccines. It has the advantage of being able to make a large number of vaccines very quickly, but it hasn't been approved for other vaccine and hasn't been proven yet as an effective vaccine modality. AstraZeneca is working with the University of Oxford, which has a chimpanzee virus-based vaccine that looks quite promising. That's a more traditional killed virus vaccine. CanSino Biologics is a Chinese pharmacologic company that's also working on a similar type of vaccine. Sanofi Pasteur, which is one of the big vaccine makers in the world, is currently working on some killed virus vaccines, as is Pfizer Pharmaceuticals. But until we have a vaccine, we're really stuck with the most basic type of protective epidemiologic behavior, and this is social distancing. We want people to do this right now for sure, because we are currently experiencing a very serious uptick in the incidence of disease. We know it's in our community. We know it's circulating out there. There are lots of people who carry the virus and who are infected. And so it really is our obligation as members of society to practice social distancing and to wear a mask. You're wearing that mask for your fellow citizens, not just for yourself. It says a lot about you that you're going to wear a mask and not wanting to infect somebody else. We do recommend that you avoid non-essential travel right now. It's, of course, the summertime. Everybody wants to take a trip. Driving is always a good alternative. There are, of course, calamities that can happen in cars as well. But it is probably safer than air travel right now, although the airline industry is trying to make some accommodations that will diminish the risk of infection, including better filtration, better exchange of air on the aircraft, and social distancing on the aircraft. When you travel by car, bring some hand sanitizer, bring some wipes. You can make your own wipes if you can't get them on Amazon anymore, but you can make your own with with washcloths or paper towels and a little bit of bleach. A little tiny bit of bleach goes a long way. Don't use a lot of bleach. And you can wipe off restroom door handles, etc. And then, of course, try to limit the number of people that you have at gatherings. Humans are social animals. They want to get together. I think we all desire that. We've been locked up for 3 months, and you can see the effects of that. But just remember, the virus doesn't care. It just wants to find another non-immune, vulnerable person, and that's all it wants to do. And it's very successful at doing that. During the 1918 influenza pandemic, wearing a mask was a lifesaver. People recognize this. This is actually a picture that my mother found the first week after she was sequestered at her house. And these are friends of my grandmother's in San Francisco in 1918. So even in that period, they knew that masking was very helpful in diminishing the spread of the disease. Berkeley did a very interesting study recently that looked at what the United States would have looked like right now if we had not done social distancing at all. And although we are dealing with an uptick in viral transmission right now, it would have been catastrophic. On the right side is the number of cases that we would have had by April if we had not done any social distancing and testing and isolation of individuals who were infected. But we certainly can do better. And that's going to be dependent upon leadership both at the federal and local level. And I would just like to say something about our public health officers. Public health officers are an essential part to dealing with the pandemic. Many of them recently have been having a great deal of difficulty because they've been getting death threats and a lot of criticism from politicians. They are trying to handle a very, very difficult situation. They have very limited resources. We have excellent public health officials in Pasadena. Dr. Ying Go is the head of the Pasadena Public Health Department. Barbara Ferrer is the head of the LA County Health Department. Both of them are highly trained, intelligent, fact-based individuals who give good information. And I think that it's our duty as citizens to support the Public Health Department. Going forward, this isn't going to be the last pandemic we have to deal with. And so I think that it's imperative that we recognize the importance of other agencies like public health, in addition to hospitals, supporting hospitals and healthcare workers, as so many of you have done over the last 3 months with Huntington Hospital. We don't want to end up with a Black Death situation where a quarter of the planet's population dies from this disease. But it is going to be a challenge, and we are going to continue to have to think about alternative ways to handle the situation. We have to continue testing. We have to do testing on a much more aggressive level. Testing is good for controlling this epidemic. We can identify individuals who are infected and may not know it, recommend that they isolate themselves and not spread the disease. We need to make decisions based on facts and science. That's the only way we can get out of this. We are highly intelligent creatures, and I think that it's going to be science that will get us through this pandemic, and we have to pay attention to what our scientists and health officials are telling us. The economic factors in recovery are going to be a Herculean lift for local and federal government, and certainly have important impacts on all measures of society. So I think that that's going to be something that's going to be lasting for the next several years. We have to address the vulnerability of populations, our elderly. We have to revisit how we house them in assisted living facilities and in nursing homes. Our lower socioeconomic individuals, people of color, people who are affected by this disease in disproportionate amounts to others. Access to health care has to be paramount, of course, and its ability to deliver and the new technologies that physicians and nurses and EMTs and first responders can use to help protect them from this disease, but also to facilitate better care for our patients. City planning. Congregate living is a bad thing in pandemics. We have to really look at how we create societies and how we plan cities, more open space, more green space, how we transport people around the city. Technology will get us out, and I think there's going to be some very big developments in technology because of this pandemic. Climate change is driving this as well. It's very clear that this was a zoonotic infection. The more we encounter viruses in forest areas that are destroyed, the more likely it is that we're going to have more pandemics. And so it's so important to address the issues that are affecting, all of the issues that are affecting our ability to live on this planet. And finally, being vigilant about future pandemics. It's important that we establish global surveillance networks to identify pathogens and areas of problems very quickly so that we can shut it down right at the source of infection. And finally, it's not uncommon during these periods to have social change and to have upheaval. We saw it during the HIV pandemic in the 1980s it affected a largely marginalized population, our LGBTQ communities, and it was organizations such as ACT UP, which were quite military, quite vigilant and quite activists, that really changed the HIV pandemic. They got the government to pay attention. They got the government to develop fast tracks for antiviral medications, and for that reason, now we can treat HIV very effectively. And I think you're seeing the same thing during this pandemic. Very difficult situations stir up people's social consciousness, and it's important that we recognize that different populations are affected disproportionately with this disease, and that we come together as a society and really address equality and some of our histories that have made those inequalities, because it affects all of us. So I'd be happy to take some questions, and I will conclude there. Going to the grocery store, yes. Yeah, so again, here we go. Yes, how safe is it for seniors to shop at grocery stores using masks and social distancing? And the lunch was excellent, very good. Thank you to the University Club. It is, during a pandemic, the safest thing is to stay at home and never go out again. Now, we can't do that. You have to eat, you have to get your groceries. Not all of us have somebody who's able to go and do that for us. And so it's all about harm reduction. And again, I think many of the grocery chains are trying to accommodate people in a safe way and to protect their own workers. Wearing a mask, a good mask, a high-quality mask when you go to the grocery store is a good idea, to stay masked the entire time, to really try to keep 6 feet away from people. I believe that most grocery stores have lines and marks now that, sort of like I said, Trader Joe's I know does a good job with that, limiting the number of people that are in the store at any one time. If you walk into a store and there's lots of people around and they're in close contact with one another, then you probably should pick another time to shop. I do know that many stores, I think Bristol Farms does this, and Vaughn's, I believe, have senior hours when there's less people. Usually those are early in the morning, because as we get older, we get up earlier. It even happened to me. So those might be good times for you to shop. If you can have one person do it all the time, it's probably better than having multiple people going and exposing themselves. People that learn how to protect themselves at the stores, I think, are very facile at trying to make sure that they don't come in contact with the virus. Bringing the groceries home, washing what you can wash off, wipe down the bags if you can, and that's about the best you can do. And the likelihood that you're going to get it is relatively small. Again, if you limit the number of time that you're in the store, you wear a mask, and you keep social distance. So the question is, what is your plan at Huntington with employees contracting COVID? Are all of your employees tested? What happens if employees are exposed and contract COVID? Well, as many of you know, one of the risk factors for acquiring COVID is to be a healthcare worker. And we have had some individuals become positive in taking care of patients. We spend an extraordinary amount of effort and time in trying to protect our healthcare workers with proper PPE, with abundant supply of PPE. And again, thank you to our donors, because many of you have helped contribute to that. And to educate them about how to decrease their own risk. Now, we know that individuals who are taking care of people with this disease, especially in our ICUs and up on the COVID cohorts, have a long period of exposure to the virus. And there's many opportunities for them to become infected, whether there's a break in PPE whether they happen to touch a contaminated surface, whether when they're taking their special equipment off, they happen to contaminate themselves. It does happen. We are testing regularly our employees up on those wards, and we are implementing random testing programs periodically to assess those individuals that are high risk. In an employee who becomes positive, they are required to go home and isolate until they are not symptomatic any further, and then we retest them before they come back and go back to work. So we're trying to decrease the amount of spread of the virus. We've been very successful at doing that in the last few months, perhaps more so than some of the other institutions around town, but this is a known factor. It has happened at our facility. It is something that you just have to deal with and recognize that it's going to happen to healthcare workers. Elliot asks, what are your recommendations from having elementary school students return to school in the fall, either full or part-time? Yes, this is an enormous, enormous challenge. I have many of my friends are school teachers. My brother's a third grade school teacher, and I'm actually working with some of the local colleges and deciding whether their college students can go back to school. I don't believe the LA city school districts have come out with the plan yet. It's a really big challenge. How do you corral third graders in a room where you've got 25 students? And I think that that's going to take some very, very careful decisions. Again, engaging children so that they understand why they have to wear a mask, why they can't touch every surface that they encounter, to try to socially distance them, perhaps to have hybrid models of classrooms with certainly a decreased number of students, perhaps doing half the time virtually and half the time in class. These are enormous challenges, and frequent testing if we can do it. It's a little harder to do it for the general public, but again, that's going to be something that's going to be very, very important. How confident are you in the reliability of the current tests for the virus and antigen? So the tests in general are quite reliable. We have about 4 different testing platforms that we use at Huntington Hospital. There's no question that nasopharyngeal swab tests are more accurate because you're going right to where the virus really likes to go, the deep part of the nasopharynx. They are probably more accurate than just nasal swabs and perhaps than oral testing. But there are a lot of platforms now that are being looked at for quick, easy, and hopefully accurate tests. You have to always check those tests and their accuracy to make sure that they are giving you good information, because you don't want to make decisions about where a patient will go in the hospital if you have a test that's not accurate. Again, we have 4 different testing platforms at Huntington. We look at them regularly. We look at the times, and it does happen occasionally when someone is missed. And so we certainly want to be hyper vigilant. You know, we're all on this. This is a process. Every day that goes by, we know how to deal with this better than we did the day before. But sometimes we have to be careful and look very transparently at mistakes that have happened to make sure that we don't have any further problems with that. So testing is very important. The accuracy of these tests are improving, but they still are a work in progress. Here's one about the flu shot, which I think is a good one. Typically, I take the flu shot in late October to assure immunity through California's flu season. Should we consider taking the annual flu shot earlier this year? Yes, I think it might be reasonable to, as soon as the flu shot is available, to get one. I know the hospital is developing some, ramping up our outreach to the community to provide flu shots. If ever there was a time to get influenza vaccine, this is the time. What we don't want to do is have people who have influenza, who have very similar symptoms to COVID, have to sit in our emergency room, and perhaps contract COVID there or down the road, when they're sitting in the hospital, because it was mistaken that they had influenza instead. So we want you to get a flu vaccine. The more people that are vaccinated, the less influenza we're going to have. Some of this is dependent on the efficacy of the flu vaccine, which is always a little bit of a crapshoot, but we hope it's going to be a good vaccine. But absolutely, the flu shot does not give you influenza. It's the single most important thing you can do right now to help decrease your risk for encountering coronavirus. Here's a question I always like the dog questions because I have a dog. My dog often goes to cageless daycare. My 96-year-old mother loves to have her visit. I'm wondering if petting my dog can infect my mother with the virus. We don't think that animals transmit the virus, although there have been a couple of reported cases of cats and dogs who've contracted it in very high infected areas. But we don't think that they transmit the virus. We also don't think that it's a common modality for infection. If you're really worried about it, you might wait a couple days before the visit to the elderly person with the dog. Perhaps give the dog a bath if you can, or even wipe them down with a little bit of maybe a little gentle alcohol solution. Not a lot, but just a little bit, just to kind of wipe them down a bit, and that might help protect you. Is the tracing component of test and trace keeping up with the progress in testing? How much more effective is testing with associated tracing, assuming it is? Tracing is very, very important, and then again, this is an outreach to our public health individuals. We're going to need thousands and thousands of contact tracers. Basically, it's a simple game of tracking down every person that's had contact with somebody who has coronavirus. And you think that would be easy, but it's fairly difficult. You need to have contact numbers, you need to know what the nature of their encounter was with the individual, but it's so very important to do that, because if you find someone with coronavirus, you put them in isolation and you get all of the people that they had contact with within about a 10-day period and isolate them, or at least have them self-quarantine for a while. That's how you control this disease. If there's no dogs for the fleas to jump to, the virus eventually dies out. And we could see it worked. We know it worked because we were able to do it 2 months ago. We saw our levels drop. We got down to, I believe, our lowest was 17 patients in the hospital and 3 in the ICU. Now we're back up to 44. So we know it works, and to do contact tracing, the public health departments are going to have many, many more people to help them do it, but it is a very effective and very easy way to help control a pandemic. Can you discuss the studies about blood types in COVID-19 infections? Very interesting observation is that blood types, we do know that people with type A blood seem to do worse than individuals who have O or B positive. And it's not clear whether it has anything to do with the blood typing or whether it's the gene where the type A blood antigen is. It also is sitting on a gene that has other immune modulators, and so it may be that that plays a role in how people respond to this viral infection. So immunology is a very important part of learning about this disease, and as we go forward, we're going to just have to continue to learn as much as we can. Again, the HIV pandemic has taught us many lessons. The more you study this pathogen, the more you learn about it, the more you develop effective therapies, and hopefully a vaccine in this particular disease situation, and also how to control the disease. Given the prevalence of anti-mask individuals, one benefit of restarting schools is educating youngsters away from their misinformed parents, particularly with the view towards future pandemics. Teachers are always the great sages of the world, and certainly I think that our teachers are a good resource for children for other ideas if they're not getting it at home. We would hope that parents would encourage their children to wear masks and to be respectful of other individuals. You know, kids are kids, you have to pay attention to some of their activities, but I think it is important that they be engaged in this process as well. And is it safe to go to a doctor and dentist appointment while wearing a mask? We certainly want you to wear a mask while you're there. Again, with your doctors, you might call them ahead of time and see if they have people waiting in a waiting room or whether they want you to wait in your car. Give them some information that when you're coming. The dentists, usually they will take appropriate precautions in terms of protective gear, and so certainly you want to wear a mask until you're actually sitting in the dreaded dental chair and about ready to be attacked by all sorts of mechanical instruments there. I'd like to thank Dr. Morgan and Jane Hatterline and Kathy Chadwell and Jamie Smith for allowing me to participate. It's always a pleasure for me to be part of these outreaches, and I know many of you, and you really make Huntington a terrific place to work. All our community, we can get through this. It's going to be a very, very big challenge in the next few months, if not several years, but we have to do this as a community, and I know we can do it. Thank you very much.